And it is a wonderful opportunity for all of us. Thank you, ICCM, for giving us this opportunity. And my dear sisters who have joined and who are going to join, this is a very, very pertinent and important topic in any ICU as well as in the ward as well as cabin, wherever you say, because blood transfusion happens everywhere and forms a very, very important component of any treatment anywhere, like a surgical patient, cardiothoracic patient, medical patient, GI bleed patient. Everybody requires some sort of transfusion at some time. And as transfusions are very, very, very common, so are the transfusion reactions. That is why this topic we face day in and day out. So learning objectives will be to understand acute transfusion reactions, how to identify them, how to manage them. As we understand, transfusion therapy is like a replacement therapy or a therapeutic therapy. The primary goal of giving transfusion is to restore intravascular volume with whole blood or albumin, to restore the oxygen capacity of blood by replacing the red blood cells, to replace clotting factor and correction of anemia. Blood transfusion is a process of transferring blood-based products from one person into another through an IV line. Transfusion carries the risk of adverse reaction and transfusion transmitted infections. Roughly 350 to 450 ml of blood is collected from a donor into a plastic bag containing anticoagulant, and this is called 1 unit of whole blood. Red blood cell concentrates are whole blood or blood component. We saw that red blood cell with something we call as a red blood cell concentrate. We are discussing about blood components over here. There's another thing called platelet concentrate, which contains only platelet, and if given enhances only platelet. And there are fresh frozen plasma, there are cryoprecipitated, there are plasma or platelet collected by apheresis. When we say apheresis, it's a method of collecting plasma or platelets directly from the donor, usually by a mechanical method. As you can see, from a RBC, we get whole blood. This whole blood can be easily divided into red blood cell and platelet-rich plasma. Again, platelet-rich plasma after second centrifugation can give rise to platelet concentrate or fresh plasma. Fresh plasma upon further treatment can lead to give rise to FAP or a cryoprecipitate. Effects of storage on whole blood. When you store whole blood for a longer duration, what happens to it? It causes reduction in pH, blood becomes more acidic. It causes a rise in plasma potassium concentrate because there are a lot of hemolysis. So intracellular potassium goes into extracellular space. So whenever you are giving blood, make sure that you have checked the potassium properly of the patient before. Progressive reduction in the cell content of 2,3-diphosphoglycerate, 2,3-DPG, which may reduce the release of oxygen at tissue level until 2,3-DPG is restored. Loss of all platelet function in whole blood within 48 hours of donation. Reduction in factor 8 to 10 to 20% of normal within 48 hours of donation. Coagulation factors such as 7 and 9 are relatively stable in storage. Coming to types of blood transfusion, number one is fresh blood transfusion, where blood less than 24 hours old from the time of collection are transfused. Second is autologous transfusion, where blood collected from a patient for a retransfusion at a later time into the same individual. Like we are going for a major surgery around 15 days from now, you have collected some blood from you, we are giving your blood to yourself only. Massive transfusion, where this terminology is most commonly in warlike scenario, where number of units transfusion in 24-hour periods exceeds the recipient's blood volume. Multiple transfusion, when repeated transfusion of blood over a longer period of time, like thalassemia or severe sickle cell crisis, there we give multiple transfusions. Indications of blood transfusion, whole blood we give whenever there is a whole acute blood loss like trauma, shock, or a neonate in exchange transfusion. And you should give a filter for platelet and coagulation factor, which should not get activated. Packed red blood cell, which is stored at -2 to -6 degrees centigrade, preferably given in chronic severe anemia, leukemia, and thalassemia. Nowadays, whole blood transfusion has gone into disrepute. More importantly, because of the more reaction, what we are following are packed red blood cells, mostly component transfusion are more into practice, which is mostly packed red blood cell are replacing whole blood in practices. Coming to other components after blood, I mean PRBC, packed cell RBC, there is something called platelet concentrate. Platelet viability is optimal at 22 degree to 24 degrees centigrade, but storage is limited to 4 to 5 days. Unfortunately, it's a very, very important component which, if collected, has to be given within a 5-day duration. Dose roughly is 1 unit per 10 kg of body weight, increases platelet count by 50,000. So thrombocytopenia less than 20,000 is roughly, some guidelines have said we should be giving platelet transfusion. Bleeding due to platelet dysfunction can also be given, like somebody on ecosprin and clopidogrel bleeding severely. That could be dysfunctional platelet where we give platelet concentrate. Also a malignancy, also a major surgery. Most important thing, take home message from platelet is that if collected and prepared, it has to be used within 4 to 5 days. Fresh frozen plasma, they are the very, very beautiful because they can be stored for 12 months at 18 degree or cooler. Liver disorders, and DIC and coagulation factor deficiency require just fresh frozen plasma transfusion. Coming to cryoprecipitate, they are the precipitate formed or collected when FFP is thawed at 4 degrees. Storage after collection, refrozen and stored up to 1 year at 18 degrees centigrade. Like FFP, they can also be stored for 1 year. And mostly given in hemophilia A, von Willebrand's disease, and fibrinogen deficiency. What test we need to do before transfusion? Number one is ABO and RH blood grouping. Patients and donors' blood sample are collected. They are cross-matched for blood grouping and RHT typing so that there won't be any reaction. So major cross-match are between patient serum and donor cell. Minor cross-match between patient cells and donor cells. So what we need to understand that donor RBC are cross-checked with patient's serum. This is how we check for blood grouping. And along with blood grouping, we check for HIV 1, 2, HBsAg, HCV, AIDS, hepatitis C, B, also should be syphilis and malaria as well. The reason is very simple, because all these are transmissible disease. So unfortunately, none of the donor patients should get this disease if recipients previously to carrying this disorders. So what do we observe before blood transfusion? We observe temperature, we observe pulse, we observe blood pressure, we observe respiratory rate, because if there is any reaction, there will be strong changes to these 4 parameters. So unless we have a pre-transfusion checklist of temperature, pulse, BP, and respiratory, it is difficult to assess if there is a reaction or not. So coming to our topic today, transfusion reaction. So if there is a transfusion reaction, what are these? Number one are infectious, viral, and bacterial, which we will be discussing very less. Rather, we'll be discussing more about non-infectious transfusion reaction. Number one is reaction to RBC antigen. We call it as acute hemolytic transfusion reaction, which are most dreaded reactions. We on a shorter note, we call it as AHTR. So acute hemolytic transfusion reaction, delayed hemolytic transfusion reaction, and reaction to donor protein. We call it as minor allergic reactions or anaphylactic reactions. So majority hemolysis occur due to RBC antigen, and if there's a reaction to donor protein, there occur allergic reaction, which are a little bit less severe, at times might be dangerous also. Coming to white cell related transfusion reaction, there could be febrile reaction, there could be transfusion related acute lung injury. So majority of the transfusion reaction are immune mediated. So again, putting forth all this together, there could be acute hemolytic transfusion reaction, there could be delayed hemolytic and serologic transfusion reaction, there could be febrile non-hemolytic transfusion reaction, there could be allergic reaction, there could be anaphylactic reaction, there could be graft versus host disease, there could be transfusion related acute lung injury, there could be post-transfusion purpura. Coming to non-immune mediated transfusion reaction like fluid overload, somebody with a very low ejection fraction, if you give 1 or 2 units of blood within 24 hours, that could be chances of fluid overload. If you're transfusing large amount of blood of low temperature, that could be hypothermia. If you're giving large amount of long stored blood, that could be hyperkalemia or some sort of electrolyte deficiency. That could be iron overload in chronic transfusion. That could be severe hypotensive reaction secondary to allergic reaction. So these are the things that has happened. Now, those who have joined, I have a question for you. A 46-year-old male with GI bleed develops temperature rise to 101 Fahrenheit 3 hours after blood transfusion. There is no hypertension, no rigor, no breathlessness. Only there is a temperature rise. So I'll pause here. I'll tell participants to put their answers in the chat box. Is it 1, AHTR, means acute hemolytic transfusion reaction? Is it 2, delayed hemolytic transfusion reaction? Is it transfusion-associated lung injury? Okay. Or is it febrile non-hemolytic transfusion reaction? Okay. So I would pause over here and tell the attendants to sign. Okay. Some of them have already answered. Please, I'll pause here. Please, all of you can answer the question. It is 1, 2, 3, or 4. So only a rise in temperature of 101 degree Fahrenheit 3 hours after blood transfusion. What are the possibilities? Okay, this is a febrile non-hemolytic transfusion reaction. So 3 was the answer. How is it? The definition is that if there is a rise in patient temperature of more than 1 degree centigrade associated with transfusion without other fever precipitating factors. So onset is mostly 3 to 4 hours following transfusion. Reaction induced by cytokines, mostly in patients with multiply transfused patients or multiparous women, occurs with approximately 1% of PRG transfusion, approximately 20% of the platelet transfusion. It is divided into mild, moderate, and severe. Mild are those where there occurs unexplained temperature rise of at least 1 degree centigrade, but less than 1.5 degree centigrade from pre-transfusion baseline, occurring in the absence of chills, rigors, respiratory stress, and hemodynamic instability. Moderate, when we call it as unexplained temperature rise of at least 1 degree centigrade, but not meeting criteria for either mild or severe. Severe, unexplained temperature rise of more than 2 from pre-transfusion baseline chill. So depending on the rise of temperature, we call it as mild, moderate, severe. But these are usually benign. You have to stop the transfusion. You have to check label and recipient identity, either we have either any cross-match identity problem or not. Slow the transfusion reaction if mild. If you're giving little bit faster rate, slow the rate a bit. Paracetamol 1 gram is good enough. Steroids are not required. So it's a very benign febrile non-hemolytic transfusion reaction where we need only to stop or slow the transfusion, give a paracetamol and wait patiently. Now question number 2. Again, there is a choice. All of you can put the answer in the chat box. A 56-year-old female develops severe rigor with hypotension within few minutes of starting blood transfusion. What is the immediate action? So question number 1 was after 3 hours patient developed fever. Question number 2 is that there's a severe rigor and hypotension within few minutes of starting blood transfusion. So I'll pause over here. All of you can answer A, B, C, D. A is what is the immediate action? A is IV fluid. B is noradrenaline. C is diuretic. D is hydrocortisone. So please put your answer in the chat box. I'm waiting. Okay, somebody did D. Okay, any other answers? I'll wait for 30 seconds more. Any other answers?
People are searching here option evil तो है ही नहीं.
So you can, whenever chat you can take, whenever I'm pausing, Dr. Jayaprakash, you can take over regarding interact with the nurses. It's up to you.
Yeah. Please type your message in chat box.
So Jayaprakash, shall I continue?
Yeah. Let's proceed, sir.
Yeah. Okay. So so we got 2 choices. Let us see what is the answer over here. So it's an acute hemolytic transfusion reaction, or in brief AHTR. It occurs when incompatible RBCs are transfused into a recipient who has preformed antibodies, usually AB or RH, like somebody given delivery a few months back and again having another blood transfusion. So antibodies activate the complement system, causing intravascular hemolysis. Occur within few minutes of starting the transfusion. Key over here is that it starts immediately after starting transfusion. It doesn't give much time because there is already preformed antibody. They immediately hyperact whenever you are giving blood. This hemolytic reaction can occur with as little as 1 to 2 cc of RBC. Labeling error is the most common problem. It can be fatal. This is one of the reaction where you have to hyperact because this can cause death. Wherever there is death following blood transfusion, mostly this is the cause. So within minutes we have to act. Labeling error has to be cross-checked. It can be fatal. 3 things we need to remember. What are the signs and symptoms? Fever, chills, rigor, nausea, vomiting, severe hypertension, severe tachycardia due to bradykinin release due to inflammatory mediators, flushed and dyspnea due to histamine release, chest, abdominal, low back pain due to cytokine release, headache, hemoglobinemia, hemoglobinuria like black urine, oliguria with dark urine or anuria, pallor, jaundice. In the long run, patient will land up in DIC. Treatment: stop transfusion. Check level, as I told, replace IV set and start normal saline. As you say that only, as we saw that only 1 or 2 cc of RBC can cause this. If you are going to start a normal saline within the same IV line, another 2 ml or 1 ml of blood will enter into the bloodstream. So immediately IV set and IV line has to change, because that IV line cannula can be containing some amount of blood that can again further cause reaction if you flush a normal saline through this. So you have to treat shock immediately, maintain blood pressure by IV saline infusion. That is the answer, IV saline and vasopressors. Investigate possible DIC and treat if clinical significant bleeding. Diuretic, yes, can be given after giving IV fluid. If patient develops some amount of reaction on the lungs, we have to start diuretics or mannitol, may help to maintain urine flow. Hydrocortisone may be considered. Samples to assess renal and liver function, DIC, hemolysis, that is full blood count, liver function test, LDH, haptoglobin, direct Coombs test should be sent immediately to check whether hemolysis is happening or not. Coagulation parameters like PT, APTT, INR, and platelet should be checked, and you have to send for hemovigilance notification to blood bank. Nowadays, blood banks are very active. Any sort of transfusion reaction has to be reported and assessed centrally. So you have to give a notification to blood bank if that sort of reaction has happened. Now coming to another part of this acute hemolytic transfusion reaction, something called a delayed hemolytic transfusion reaction. It usually occurs to a patient previously sensitized with an antigen due to transfusion or pregnancy. A fall in titer over time may make incompatibility undetectable. A subsequent transfusion may recall the antibody causing hemolysis followed by a falling hematocrit 5 to 10 days earlier. The hematocrit will continuously fall until all the transfusions are destroyed. So this is a transfusion reaction which occurs a little bit delayed and 5 to 10 days after transfusion, and it continues to happen unless all transfusions. It's a slow type of reaction which may not be life-threatening, occur in a delayed basis. Onset usually 1 to 7 days post-transfusion, but may be up to 28 days. Worsening anemia and jaundice from destruction of red cells, often asymptomatic, but rarely splenomegaly, hemoglobinuria, and hemoglobinuria can occur. Renal impairment may occur in severe cases. What we need to do? We need to do a full blood count with film comment. Direct Coombs test may be negative, but should be sent for. Blood group antibody screen should be done. Liver function test should be done. Haptoglobin considered false when hemolysis is occurring. Now we got 3 reactions now: febrile non-hemolytic reaction, acute hemolytic reaction, delayed hemolytic reaction. Now question number 3: a 22-year-old female developed urticarial rashes all over the body 1 hour after transfusion. What are the possibilities? Number A is acute hemolytic transfusion reaction. Number B is delayed hemolytic transfusion reaction. Number C is allergic reactions. Number D is TRALI. Over to you, Jayaprakash sir.
Yeah. Please reply your answer in chat box and see the time frame. See time frame. B. Anyone? Type your message. Symptoms was urticarial rashes all over the body 1 hour after transfusion. So what will be the possibilities? Two one wrote type B. Okay, sir, proceed.
Okay, fine. So as Dr. Jayaprakash sir told repeatedly, 1 hour after the reaction. So delayed occurs after 5 to 10 days. So this is allergic transfusion reaction. So allergic reactions are very minor reaction. Frequency is 1 in 100 blood transfusion to 1 in 500 blood transfusion. More common with plasma or platelet. More common in FFP and platelet components. Onset from the commencement to 4 hours after transfusion. Recipient may have an antibody reacting with an antigen in the transfused product. Minor or localized reaction like flushed skin, morbilliform rash with itching, urticaria, angioedema, periorbital itch, erythema, conjunctival edema, edema of the lips, tongue, and uvula. All these things can happen. Or throughout body, there could be urticarial rash. Management, slow the transfusion. Check label and recipient identity, histamine like loratadine, cetirizine can be started. If symptoms are troublesome, like if there are more itching, you can start cetirizine. If symptoms are mild and transient, transfusion may resume. Continue transfusion at slow rate with increased monitoring of BP and pulse and temperature. Send hemovigilance notification again to the blood bank. If symptom increases, treat as a moderate to severe reaction. So allergic reaction, as I told, not that uncommon. I told on mild is 1 in 100, moderate are 1 in 500, and onset usually within fast 50 to 100 ml of infusion. Moderate to widespread reaction can also occur in allergic form like cough, hypotension, tachycardia, dyspnea and oxygen desaturation, chills, rigor, loin pain, angina, severe anxiety. All these things can happen in a severe reaction. Management, like you have to stop the transfusion. I think somebody has raised the hand. Okay, fine. I'll continue. We'll take up the answers at the end. So management is stop transfusion, check label and recipient identity, replace IV set and give saline to keep vein open and maintain BP, monitor closely and treat symptomatically as required with IV fluid, oxygen, antihistaminics, send hemovigilance notification to blood bank. So these are the allergic reaction. Coming to the most dreaded from allergic reaction, we call it as anaphylactic or anaphylactic allergic reaction, whose frequency is a little bit less, 1 in 20,000 to 1 in 50,000. It's very rapid in onset, may be due to an antibody in the recipient reacting with the plasma protein in a blood component. As I told you, whenever there is a reaction of the protein in the blood component and antibody present in the recipient, there occurs anaphylactic reaction. Usually occurs in IgA deficient individuals. There could be life-threatening reactions like symptom as per moderate reaction and severe hypertension, shock, tachycardia, widespread urticaria, wheezing, stridor, change in voice, severe anxiety. Treatment, stop the transfusion, check label and recipient identity, follow anaphylaxis guideline like ADR 1 in 1000 IM or repeat at 5 to 10 minutes interval. If required, further doses can be given. Replace IV set like acute hemorrhagic transfusion reaction, give IV crystalloids and colloids, adult 1 liter, children 20 ml per kg until systolic blood pressure more than 90. Consider hydrocortisone, consider H1 antihistaminic, loratadine, H2 antiviral may be added for severe reaction, may require continuous positive airway pressure ventilation, may require a chest X-ray to find out how bad is your lungs after the reaction. Question number 4. 4 hours after blood transfusion, a patient develops drop in saturation and requires increased oxygen requirement. What is the diagnosis? Over to you, Jayaprakash sir. I'll just I'll write say the full form. A is acute hemorrhagic transfusion reaction. B is delayed hemorrhagic transfusion reaction. C is transfusion associated lung injury. D is transfusion associated cardiac overload. These are 4 choices. Jayaprakash sir, over to you.
See, here there are 2 important things. What is the time and the volume of blood? You have to look at that one. Here, the question is that 4 years after blood transfusion, patient developed drop in saturation and required increased oxygen requirement. So what will be your diagnosis? Whether it is acute case, acute hemolytic transfusion reaction, or delayed, or TRALI, trauma-related acute lung injury, or TACO. D. Someone type D. C. Someone type C here. D, C. Anyone? So this is two-way communication. Once you will raise hand, I will allow you to speak. One fellow Suresh Pillai is raising hand. Will come. Okay, sir, continue.
Yeah, thank you. Thank you so much. Okay. So this is a very important, as Dr. Jayaprakash sir told, 4 hours after blood transfusion it happened. So something called as transfusion associated lung injury. Its frequency is 1 in 5,000 transfusion. Onset occurs within 6 hours following transfusion of plasma or plasma containing cellular components. Mostly with FFP it happens. A complex group of disorder indistinguishable clinically from VIDS, because after transfusion, patient will desaturate, lungs will look bad, X-ray will look bad. One recognized mechanism involves a donor antibody reacting with recipient neutrophil or HLA antigen causing cell activation that results in acute severe lung injury. So donor's antibody reacting with neutrophils. Okay. Onset of severe dyspnea and cyanosis, proceeding to respiratory failure with bilateral incidence on chest X-ray within 6 hours of transfusion. Absence of left atrial hypertension like circulatory overload, like pulmonary capillary. We won't go deep into that. Mostly this absent of in a cardiac anomaly. It should be distinguished important differential diagnosis as cardiovascular overload, we call as transfusion associated cardiac overload, other causes of acute respiratory distress syndrome, other causes of acute lung injury. If you rule out these three, it is a default diagnosis if these three are ruled out. So testing donor plasma for anti-HLA antibodies can support the diagnosis. So risk factors are shock, multiparous women, chronic alcohol use, liver transplant, mechanical ventilation within 30 more than 30 centimeter, and positive fluid balance. So transfusion-associated lung injury is associated with high morbidity, and majority of the patients require ventilatory support. The lung injury is generally transient, with oxygen levels returning to pre-transfusion level within 48 to 96 hours, and chest is returning to normal within 96 hours. Some patients are slow to recover and may remain hypoxic with persistent pulmonary infiltrates for several days, or the pulmonary function eventually returns to baseline without apparently sequelae.
Wait, sir. Someone. Yeah.
Yes, sure.
Swati means. Sweetie means you want to say something. Unmute yourself and ask. See, this is two-way communication. Unmute yourself and then you ask. Sweetie means.
If you are feeling shy or of asking, you can again type the question also. We'll answer immediately. If you are feeling shy to speak or you are unable to unmute due to some reason, you can type the question also.
You ask. Okay, sir. Continue, sir.
Okay, fine. So as with ARDS, there is no role for diuretics or corticosteroids in transfusion-associated lung injury. The mortality rate of transfusion-associated lung injury is reported as high as 20% in general population and 58% critically ill population. Although this looks a very trivial refercation of a blood transfusion, but in a critically ill patient where already lungs are compromised, already patient is in organ failure, already there is a pre-existing some sort of ARDS, mortality rate is very high. So transfusion-associated lung injury should be identified early and suspected early and treated early. Coming to the important differential diagnosis of transfusion-associated lung injury is transfusion-associated circulatory overload. It is rapid onset after infusion of a volume of fluid that is clinically significant for affected recipient. It means that, as we know, transfusion-associated lung injury occurs 4 to 6 hours after the transfusion, but transfusion-associated circulatory overload or TACO that occurs within half an hour to 1 hour after even, in fact, receiving the blood. Most risk factors are premature or newborn, where a slight increase in blood volume also causes this TACO. Elderly patients with impaired, like somebody with the LV dysfunction, like EF 20%, where you give suddenly 1 unit of blood rapidly, there also it can happen. Renal failure patients who are oliguric or anuric, there is a chance that suddenly they'll develop breathing difficulty following transfusion. If infusion is too rapid for the recipient, like somebody with a young, like 10-year-old, you have rapidly transfused within a span of 1 hour due to some reason or accidentally, that can also cause. If volume infused too great is specifically normal. If already patient is volume overloaded, you have already given him 3 liters of fluid pre-transfusion and you are giving blood, then there's a problem. If there is due to some reason acute heart failure, like somebody you are transfusing blood, suddenly patient goes into LV dysfunction due to acute MI, there also it can cause. So how can you prevent it? Slow the infusion rate and lower the volume of transfusion. So to prevent TACO is very easy. Do not be in a hurry or hasty to give blood transfusion, even if your duty are finishing. Slow, you can start slow. And if you are suspecting TACO also, then also if blood is required, you have to give. If blood is not can be postponed, you can stop it. If blood is definitely required, slow the transfusion rate so that body can accommodate the new volume. What are the clinical features? There is a sudden increase in blood pressure, sudden rapid bounding pulse because patient becomes hypervolumic, patient is tachypneic, dyspnea with pink for the sputum, oxygen desaturation consistent with pulmonary edema, bilateral crepitation, raised JVP and CVP, and X-ray chest showing acute or worsening pulmonary edema, restlessness, anxiety, ultrasound showing multiple B lines. Management is stop transfusion, oxygen, diuretic, non-invasive ventilation may require invasive ventilation, Demonstration of raised PNP may help to distinguish from TRALI. So, how to distinguish from TRALI? NT-proBNP, which is very important marker of pulmonary edema or cardiac failure, if that is pretty high in transfusion-associated circulatory overload compared to TRALI, because they form very important two differential diagnosis. Coming to the non-immunogenic, something called bacterial contamination or bacterial sepsis. They are more common and more severe with platelet function. Even if you have understood that mostly packed RBC are less notorious, more notorious are platelet and plasma, which causes allergic reaction as well as more bacterial sepsis. Organisms with platelet can be gram-positive organism mostly like Staphylococcus and Streptococcus, and in packed cell mostly are Yersinia and Enterobacter. Symptoms are rigor chill fever, like somebody developing severe rigor chill fever following a blood transfusion means there could be some sort of storage defect where blood is an important media for growth of bacteria. If you have not stored at adequate temperature, if during transportation blood has been exposed to normal temperature for longer duration, there's a high likelihood of bacterial growth in it, and whenever this blood is transfused to the recipient, there is a sudden rigor chill and fever, and most of the patient land in shock, usually within minutes of starting transfusion, because suddenly you are somewhat like infusing a lot of bacteria into the blood. There occurs respiratory distress, wheezing, oxygen desaturation, pain in the arm, chest, back, loin pain, nausea, and treatments are mostly antibiotics. Number two, non-immunogenic reactions are hypothermia. It occurs progressive onset during rapid transfusion of large volume of cold fluid, like somebody bleeding heavily. You have asked for 10 or 20 units of blood and you are pumping in 4 to 5 units of blood, and temperature, you do not have time to normalize the temperature. There it occurs. Mostly occurs in children. And it occurs whenever there's a high volume of blood product like 50 ml per kg per hour in adult or 15 ml per kg per hour in children. Signs and symptoms like reduced temperature, patient becomes hypothermic, may be associated with cardiac rhythm irregularity. Like when hypothermia, if you're suddenly exposed to a lot of hypothermic fluid, there occurs cardiac arrhythmia. Impaired platelet function and coagulation. Management, limit heat loss from recipient and monitor BP-TPR. If further blood components required, infuse through a warmer. There are certain infusion warmer are available where you give the blood through the warmer, so that if you do not have you do not have time to raise the temperature outside the patient's body while it is going through the body, if it goes through the warmer, there's a chance that there's some temperature warming occurs through the warmer. There's certain thing called chronic transfusion reactions like alloimmunization, transfusion associated graft versus host disease, iron overload, transfusion transmitted infection, post-transfusion porphyria, which occur onset within 5 to 12 days after transfusion of cellular blood components, severe thrombocytopenia, often with porphyria and possibly other bleeding. Thrombocytopenia will persist for 1 to 2 weeks. No need to bother about that, because what we are more concerned about is acute transfusion reaction. Chronic transfusion reactions are difficult to diagnose and need some amount of help. It will give time. But for us who are working in critical care, more important are acute transfusion reaction, which needs immediate action to avoid life-threatening things. There's a transfusion-related graft versus host disease. You can see all these rashes, which we rarely see in ICU. There's a hematologist forte. So putting it all together, if you ask us how to put it all together, generally transfusion reaction can be divided into category 1, which are mild reactions like urticaria, itching, results of hypersensitivity and local histamine released to protein prevail in the donor plasma. Signs and symptoms like local cutaneous reaction, often accompanied by pruritus, occurs within minutes of commencing the transfusion. The symptoms usually subside if the transfusion is slowed and aspirin is given. Management are slow the transfusion, give some sort of antihistaminic, continue the transfusion at normal rate if there is no progression of symptom after 30 minutes. If there are no clinical improvement within 30 minutes, if signs or symptoms worsen, treat the infection as category 2. Category 2 is moderate allergic reaction or anaphylactic reaction, which is mostly by symptoms of anxiety, palpitation, headache, pruritus, dyspnea. Signs include fever, urticaria, rigor, tachycardia, and flushing. Management, you have to stop the transfusion and replace the infusion set, keep the IV line open for the normal sign. That is very important. The minor reaction, you can start, but in the moderate reaction, please stop, change the IV set, we'll wait. Administer antihistaminic, administer antipyretic, avoid aspirin in thrombocytopenia patients. IV corticosteroid and bronchodilators can be considered if there is an anaphylactic features like bronchospasm and stridum. Collect urine for next 24 hours for evidence of hemolysis. If there is a clinical improvement, restart the transfusion slowly with a new unit of blood and observe carefully. Category 3 are life-threatening reactions, which I have told already, acute interstitial hemolysis, which occur due to cross-matching failure mostly. And there could be bacterial contamination causing septic shock. There could be TRALI, transfusion-associated lung injury. There could be transfusion-associated circulatory overload. There could be anaphylactic shock. Symptoms include anxiety, chest pain, respiratory stress, low inner back pain, headache, dyspnea, signs rigor, fever, restlessness, shock, tachycardia, hemoglobinuria, and unexplained bleeding. Management: stop the transfusion, check label and recipient identity, replace the infusion set, keep IV line open with normal saline, infuse normal saline to maintain systolic BP, vasopressures, maintain airway, give high flow oxygen by mask, give 1:1000 ADR or 0.01 milligram per kg body weight by intramuscular injection. Children, little bit less dose. And IV corticosteroids, consider IV cortisone at 4 mg per kg in pediatric or 200 to 400 mg. And bronchodilators if there are anaphylactic features. Diuretics can be given to maintain urine output. Consider anti-allergenic H1 antihistaminic, loratadine and cetirizine, or ranitidine may be added to severe reaction. I think I'll stop over here. Dr. Jayaprakash, over to you.
Yeah.
Thank you.
Suresh Pillai, you want to ask some question. Suresh Pillai, unmute yourself. Do you want to ask anything? Suresh Pillai. Okay. So in most of the slide, you have seen that the stop transfusion. So prevention is always better than treatment. If you will see that most of the blood sample, there is one paper. So better you always cross check that with file, that patient name, which component, which type of blood group, whether RS factor positive or negative. Twice at least you have to check it, because if you will just take up in your regular practice, so it will be always easy for you. So be vigilant when you are going to transfuse blood. And one more thing, that at least you monitor the patient for 10-15 minutes. Now, if any question, please ask or raise your hand. Anyone? Or you put your question in chat box fast. Okay, I feel that what you taught, it's clear for them. Now, two things. Suppose, Dr. Pragyan sir, that once a patient is coming, and so I'm talking about the rate of speed, because sometimes we need, is in cases of hemorrhage, patient need fast blood transfusion. In cases of major surgery, patient need fast blood transfusion. And if a patient in ICU and we are going to transfuse the blood, so what will be the speed and how much time we will take to transfuse one PRBC packed cell?
Right. So this is a very interesting question. Thank you, Jayaprakash, for putting it forth, actually. So we have always cross-checked how slow we can give, how fast we can give. There is always a debate. Okay. So as per our blood bank officer, there's a lot of dispute in it. You can give blood transfusion till 4 to 6 hours. If you are in some problem, you want to give very slowly, 4 to 6 hours is the longest duration time. So idealistically, but depending on the climate we are staying, like in India, so there is always a chance of bacterial contamination if we keep the blood outside at normal or a very high temperature as we are having. So it is always ideal to finish the blood between 3 to 4 hours is the ideal time. But as in critical care, our reaction should be right for the patient. If somebody is bleeding heavily, somebody is acutely hemorrhaging, as you told correctly, somebody having severe GI bleed, same blood can be transfused in a duration of 15 to 30 minutes. We can push it through 50 ml syringe as well. That is very important. Longer duration, 3 to 4 years, 3 to 4 hours, even it can be given within 15 minutes or half an hour if the patient requires it as such.
Yeah. And one because there is always confusion. So this is nursing class. So I would like to put one more question, that suppose that most of the time we have seen that the blood is keeping that in refrigerator. So the temperature at that time will be definitely cold blood. Cold blood means the temperature around uh, 8 degree or like that. So in that cases, can we hold time, take time to transfuse the blood?
Yes, so there's a question. Idealistically, we should bring the blood to normal temperature, at least keeping in some sort of inside the cloth or in the tummy of the patient for around 15 to 30 minutes to bring the blood to normal situation. Saying that, like somebody undergoing a CABG who's requiring immediate surgery, somebody acutely hemorrhaging, their use of warmer has also been appreciated. Give blood transfusion through warmer. But if you do not have warmer and you do not have this, if you do not have any other choice, you have to compromise in the temperature and take a risk and give it. But it is always ideal to bring the blood to normal temperature before giving. It is safety for the patient as well as to avoid any untoward reaction.
Yes. So the message clear that we should not start blood by taking from fridge. Then and there we should, at least we should make that on whole room temperature. And one more thing, that if because if you need to transfuse and you can't wait for more time, so better to keep blood. Generally what we are seeing, that we are keeping just putting blood packs, blood in our body temperature to make that. So it's always better to make on that room temperature. One more question someone is asking, that in thalassemia patient, if blood reaction is happened, then what we can do? Is it acute transfusion reaction or chronic transfusion reaction?
Okay, thank you. Thank you, Vaishali. Very nice question. So, like thalassemia patient, blood transfusion reaction is irrespective of the type of patient. It could be thalassemia, it could be sepsis, it could be GI bleed, it could be brain hemorrhage. The reaction should be taken in the common front. Even if it's thalassemia, we should try to know what type of reaction. If you go on to see my last few slides, it's a minor, major, or a moderate type of reaction. It's an immune reaction, allergic reaction. Then we can give anti-allergy and stop it. If it is acute hemorrhagic transfusion reaction, accordingly you have to change the IV line, put a new line, give IV fluid, give vasopressor, if required, diuretic. Coming to your next second part of the question, is it acute transfusion reaction or chronic transfusion reaction? Again, acute and chronic depend on the transfusion reaction, not like thalassemia. All the thalassemia patients are chronic in getting blood, like they're chronically getting lot of blood. They might suffer from chronic transfusion reaction because they're more exposed to more type of blood. They're more exposed to chronic transfusion reaction. But again, acute transfusion reaction can also occur to thalassemia patient, somebody with an allergic reaction. If you have not cross-checked the cross-matching sleep, another blood is gone to some patient. So it could be result in severe acute transfusion reaction. If a thalassemia patient receiving multiple type of blood, like he has received over 1 year, and then after 2 years he develops a little bit of liver problem due to iron overload, then we call it as chronic transfusion reaction. So both type of reaction can happen to the thalassemia patient, but acute reaction is always called as acute transfusion reaction irrespective of the patient. It could be thalassemia, it could be brain hemorrhage, it could be CVA, it could be GI bleed, it could be CABG patient. Acute transfusion reaction is always acute transfusion reaction irrespective of the etiology of the patient for which you are giving transfusion reaction. I think I hope I answered your question correctly.
Yeah, it was excellent. So one more basic question I would like, that in cases of anemia, and at what hemoglobin level we should start blood transfusion? I'm not going in transfusion reaction. I'm simply asking that in cases of anemia, if hemoglobin level is down, so at what hemoglobin level we should start BT, blood transfusion?
Very nice question, Dr. Jayaprakash. It's exceptionally good question, which is a big debate. Even all the nurses must be facing in their ICU. Like some doctors starting at some hemoglobin, other doctors starting at some other hemoglobin. There is always a confusion. So to sort out this confusion, there's a very beautiful study called TRIC study, which came and which changed the guideline further. We are not discussing about OPD basis. So outer basis, somebody low hemoglobin, somebody can give blood at any level. We are talking of the ICU. So in ICU scenario, in a medical patient, sepsis patient, septic shock patient, all these patients should receive blood transfusion whenever hemoglobin is less than 7. Number 1. Somebody with an acute myocardial infarction within 7 to 10 days duration should receive blood transfusion if hemoglobin is less than 10. Why? Because all these patients require a lot of oxygen transport. So hemoglobin form a very, very important component. Unless you fill all the hemoglobin with good amount of oxygen, our heart won't be transfused, body organ won't be transfused well. So anybody with acute myocardial infarction should receive blood whenever hemoglobin is less than 10. Third part, whenever there's an active bleeding, let it be from gastrointestinal tract most commonly, or bleeding from somewhere else, or esophageal various bleeding. So in those scenario, keep a blood target of 9 to 10. That's what recommendation is there. In all rest scenario, do not react when hemoglobin is more than 7. I'll again repeat, somebody acutely bleeding, keep hemoglobin 9 to 10. Somebody with acute myocardial infarction, keep hemoglobin 10. If it is less than 10, transfuse. In all other scenario, only transfuse blood whenever hemoglobin is less than 7. Why? Because of the slides what I taught you, blood doesn't come with without any side effect. It has got tremendous side effect. Even it can cause fatality in some scenario. That is why it should be considered as a type of treatment which should be taken, which we should take extra care in giving and thinking before giving. Thank you.
Okay, so the basic role of hemoglobin is to oxygen transportation, because hemoglobin, I'm not going in detail. So the basic meant for keep hemoglobin on higher side for different in different scenario, as Dr. Pragyan sir said that for cardiac patient keep hemoglobin around 10. So the basic role is oxygen transportation. Now one more last question I would like to ask, that in ICU most of the time patient is on central venous catheter. We are putting always central venous, and through that we are transfusing the blood. Suppose that if patient came in acute stage and we have to transfuse immediately and no doctor is available at that time, nursing has to take care because they are generally expert that when we have to start the blood transfusion. So what will be the gauge size so that we can transfuse blood?
That's a very question, I think. That's a very question. Gauge size actually varies. Thicker are little bit better to avoid any sort of reaction actually. The more the wider the cannula, better it is actually. The size has not been mentioned. The wider the cannula, better it is for it.
Yeah. So generally we have to keep gauge size around 18. So that you.
Yes.
Any
correct,
more
sir.
question? I think most as Dr. Pragyan sir said, and very nicely he elaborated all the topics. So any question or any confusion? Okay, so in conclusion, so I would like to just put you remark that be vigilant, always monitor the patient, take the clinical, look out the clinical parameter, see whether patient is tachypneic, hypotension is there, or tachycardia is there. And if a patient is on blood transfusion, first you have to think about that. Just see the paper and see the note and go through that whether this is transfusion reaction or not. So I think, shall we?
Yeah. I think with this we can conclude.
Yeah. So thank you all for participating here. And I think that this will, you people will definitely utilize this in your practice. Thank you.
Thank you. Thank you, Jaiprakash sir. Thank you so much. Thank you.